So here we go. Good evening, good afternoon, and good morning to all the dentists who are watching today's special edition with Dr. Jose Carlos Martins de Rosa. Um, I don't think I need any introduction for him. He is so popular, so famous, and especially his technique, IDR, the immediate dentoalveolar restoration. It is one of the beautiful technique which I first time saw when I attended the urban regeneration symposium, the first one, and he was there as the speaker, and I had the great privilege and honor to meet him there, and I heard him, and it was an amazing technique, but definitely I would like to tell everybody that if you want to try that, you should learn it first. Don't just by going through the webinars or listening to him and then trying it. It'll be little risky, definitely, but he's going to explain it to us today beautifully. You are going to love this webinar. I welcome Dr. Jose Carlos Martins de Rosa on behalf of Kenosha and the whole team of the Global Summit. And we have been reaching millions and millions of dental surgeons all around the world. And as you can see, doctor to doctor, we are trying to unite and bring in not only dental surgeons, we are bringing chiropractors, we are bringing medical practitioners and people related to pharmacology. So it is a great effort by our team. And today, before our webinar starts, I would like to say a few words about Dr. Jose. Dr. Jose Carlos Martin de Rosa has a Master of Science in Prosthodontics and a PhD in implantology. And he specializes in periodontics. So that is very important because if you see all around the world, the best of the implantologists have a periodontic background. So either they are periodontists or they specialize into that. He has developed new approaches to the treatment of compromised sockets and to the aesthetic regeneration of soft and hard tissue around implants. Among them, the most popular is the immediate dentoalveolar restoration technique, which is he's going to explain it to us today. He is the owner of pioneering dental center, which is known as Caixas do Sul in Brazil. I'm so sorry if I have not pronounced it nicely. Maybe Dr. Jose can tell us again what's the exact way to pronounce his center. It is equipped with all the modern facilities to work with biosafety and comfort and to achieve excellence using high technology to accomplish, for example, a fully digital treatment. It is one of the biggest requirement for IDR also because he does the hard and soft tissue augmentation and temporization and everything one single day for the patient. So digitalization is very important and digital treatment is one of the biggest part of it. Offering specially developed immersion courses as well as study and research groups. The center is also a place for professional improvement. Dr. Martins also offers courses at locations in South America, North America, Europe, and the Middle East and Asia. He speaks regularly at major international congresses around the world. As I told you, he's going to be, this time again, going to be into the third International Regeneration Symposium at Urban Institute which is a world-class symposium started by Professor Istvan Arban. And he's going to be there as a speaker, and he's going to take the courses also. So anybody get a chance to go there, you should. Um, he's an active researcher and has written many articles published in the international scientific literature. He has authored a book titled Immediate Dentoalveolar Restoration, Immediately Loaded Implants in Compromised Sockets, Quintessence, 2014, and has contributed to many chapters on the same topic in other books. So this is a little comprehensive introduction of Dr. Jose Carlos Martins de Rosa. And another thing I would like to tell that I met him, as I told you, and he remembered, because he's not much onto the social media a lot. I tried to message him on Facebook Messenger. He said, Sandeep, I'm not there onto that. So, but definitely he will reply to you, to your questions. If you, in the end of the lecture, he may give his email ID, and anybody interested, they can always mail him. And those who are interested in taking up his courses, definitely you can go to other places. Let this pandemic situation come down easily. So without taking much of your time, I'm handing it over to Dr. Jose Carlos Martin de Rosa. Welcome, sir.
Thank you. Thank you so much for your kind words. It's a great pleasure and honor to be with you today. You remember for the first time that we met together 3 years ago, I think, or more, at Urban Regeneration Symposium. It was great. We had a dinner together. It was amazing. Yeah. So today, I'm gonna help you guys with some knowledge, some experience on this topic. I've been working with this methodology for such a long time. My job today is to share with you my experience on this topic. So I'm ready to start my presentation as soon as you will release me.
Yeah, definitely. You can start it, Anshul. Let him share his files, and so that we can start his presentation. Dr. Jose, you can share the screen. Yeah.
Am I ready?
Yes.
Okay. I really hope you enjoy this presentation today. And at the end of my presentation, I'm gonna give you some email address, my Facebook, Instagram, and you can be with me wherever you want. So the topic today is immediate dentoalveolar restoration. As I said before, I've been working with this methodology for a long time. And my job today is to share with you some of my experience on this topic. This is my office in the southeast part of Brazil. It's called Rosa Odontologia. In this building, we have 1,100 square meters, and we have here 7 chairs, my surgical center, and I usually use my surgical center, put the patients under sedation or general anesthesia. And I also have here my digital lab, my digital planning center, and my study center. And my study center is called Rosa Educação. You can follow us on Facebook, and this is my website, www.rosaeducação.com.br. For more information about the courses and lectures abroad and around the world, you will find it. You will find the information is in our website or in social media. And you can also follow us on Instagram. I'm not a really fan of social media, but I have people behind me that are dealing with. So contact me and I'm gonna give you answer as soon as I am free. So I have more than 1,000 participants trained here in Brazil. When I say trained, this is a 3-day course. I'm gonna give more details about this course later on. More than 500 participants trained outside Brazil. Courses given in 50 countries, and courses will be given in 54 countries by the end of this year. And here we have the topic to be discussed with you today. Here you can see a fixed prosthesis from the canine to the second premolar. In the second premolar area, we have the fracture, as you can see here, and we have also the presence of the fistula and the tissue shrinkage in the hillock side. So here we have two different scenarios. If you remove this fixed prosthesis, you can see the loss of volume in the dentular sides. But we have a huge difference about the buccal palatal dimensions of these two different scenarios. And according to my experience, a post-extraction socket would never become an edentulous site for late implantation. It's because it would increase the number of the procedures, the cost and the treatment time, and of course, the unpredictability of the outcomes. Talk about the gingival margin and papillary height position. That's why I suggested you that everything is going to be solved in one single procedure using flapless surgery. Just to keep in mind that the dentist is responsible for the decision making, never the patient. So you are responsible to decide which bone you are going to have around your implants. In the second premolar area, you have a huge defect. It's missing completely the buccal wall, and the IDR technique fits perfectly what we were looking for such a long time. It's all based on biological response. It's a bone grafting at the time of immediate implant placement and personalization in compromised sockets. Everything solved in one single procedure. And our goal is the preservation and regeneration of the natural biology. This was our first IDR clinical case. As you can see, a big fistula could be seen in the right central incisor due to the fracture. So we extract this tooth, we evaluate the dimensions of the defect at the buccal aspect, we install the implant in the correct three-dimensional position, we restart the defect using cortical cancellous graft harvest from the maxillary tuberosity, and we fully fill these gaps between the cancellous part of the graft and the implant surface with particulate bone graft harvest from the same donor area, from the maxillary tuberosity. And we made our provisional restoration immediately, of course, out of occlusion. All the provisional restoration that we install over the implants in the IDR technique are out of occlusion. In 4 months, we were in completely state of shock because we have the maintenance of the anatomical contour of soft tissue. So it was taken impression, it was made the final restoration, the porcelain restoration in place. And 14 years later, the post-op, we have the maintenance of the anatomical contour of soft tissue. And I'm gonna also call your attention to the new buccal wall completely remodeled and is still stable at the buccal aspect. So this is our goal, regardless if we replace one single tooth as we have in this case, we have the maintenance of the anatomical contour of soft tissue, or like this case that we replace two simultaneous teeth, two contiguous teeth at the same time, applying the same methodology, the IDR technique, and we have the same outcome. We have already performed this technique in more than 600 clinical cases. In cases that presented total loss of buccal bone wall, it's missing one wall, two walls, 3 or 4 walls, it's missing the mesial or distal bone ridge at the same time. And how to get hard and soft tissue stability in one single procedure using flapless surgery. According to my experience, The IDR technique is the first recommendation for such a very challenging clinical cases like this, especially in anterior zone. This is the mid-dentovelar restoration concept. This is a minimally invasive approach. This is a flapless surgery, but all credits go to the mother nature. We take advantages on bone biology. We harvest bone graft from the tuberosity using handle instruments like chisels, and we use a double layer graft, a corticocancellous graft, to restore the wall that the patient lost, plus particulate bone as a bone filler. And we install immediately the provisional restoration. But the question is, what is the importance of using a graft as a natural scaffold filled with osteoblastic cells and growth factors? Take a look here. The patient lost completely the buccal wall. And why not to use a piece of bone, a double layer graft, a corticocancellous graft, autogenous bone graft, to restore the wall that the patient had lost? And we use this piece of bone as a biological member to prevent cells competition between hard and soft tissue. And our goal is to get us an outcomes like this, to have a bulky soft tissue along the months and along the years. This was our dream, but the dream came true. This is the post-op after 10 years, before and after, and take a look at the height and width of bone at the buccal aspect, the new buccal wall, and the bone graft that we had placed above the implant platform still remain and remodeled above the implant platform. So I can say that the bone determines the gun position. Let's discuss a bit about the donor graft area for the execution of the IDR technique. We just move bone from the donor side to the receptor side, and this graft can be used as a bone filler in intact socket or for bone reconstruction in compromised sockets. And this graft is going to be used as a bone transplantation to improve the bone growth and to promote a faster and better bone graft incorporation. That's why I recommend you to do a quick manipulation. As soon as the bone is taken from the tuberosity, we reshape the graft according to the defect configuration, like a shell, like a new buccal wall. And immediately after that, we install and we insert this graft in the receptor site. Our aim here is to keep the cell's vitality in the graft from the donor area to the recipient bed. I recommend you to read this article that was published by my team in 2017. And we evaluated tuberosity clinically, tomographically, histologically, and also through micro-CTs. And the tuberosity can provide various types of graft, several ones, as connective tissue graft, particulate bone graft, corticocancellous bone graft, corticocancellous block bone graft, and also a triple graft. When both tuberosities can be considered, more graft can be harvested. How about the IDR science, the IDR based on evidence? We already have 27 articles already published about this topic. 2 more articles were recently accepted for publication. We have our book, the IDR book, that was published in 4 languages. And we wrote 10 book chapters and different main authors around the world. Here, the chronological sequence of the articles already published on IDR technique. Pay attention that the first article was published in 2008. Since then, we have published many articles in different journals, high-level journals worldwide. And the last article was recently published. This is the last one, 27. The mid-dentovelar restoration for the treatment of type 2 and 3 extraction sockets. And this is our book, the IDR book that was published in Portuguese, Spanish, English, and Mandarin language in partnership with Quintessence. All of them are sold out nowadays, and we are working very hard in the next edition that is going to be released till the end of this year. So we have 5 keys to immediate dentoalveolar restoration in aesthetic areas. The first one and the most important one is the implant stability. That should be equal or more than 30 newtons centimeter. The second one is the implant position. In anterior zone, from the right canine to the left canine, the implant has to be placed always seeking the palatal wall anchorage. The gap to be left between the implant and the inner part of soft tissue, that must be around 3 millimeters. And the thickness of the new buccal bone wall. And the last but not the least important is the emergence profile that will give us the final soft tissue thickness. During my presentation, I'm gonna give you more details about some of these keys to succeed with the IDR technique. So I'm gonna share with you this clinical case that we did we replaced these 2 central incisors. As you can see through this clinical evaluation, the patient lost completely the buccal wall. And through the CBCT scan, we noticed that the patient not only lost the buccal bone wall, but beyond the root apex. So we can consider that we have a big challenge to be solved. So we extract these 2 teeth, we confirm the absence of the buccal wall, and we apply the IDR technique. And we did all in one single procedure. We did the teeth extraction, implant installation, provisional crown fabrication, and the bone reconstruction. So this is the post-op 4 years after apply the IDR technique. You can see here the improvement at the gingival architecture position, and I'm talking about the gingival margin and the papillary height position. And I'm gonna also call your attention to the new crystal bone that's completely remodeled and stable between these 2 implants. This is what we consider the new challenge of modern implantology. So from now on, talk about this challenge. I'm gonna share with you 6 clinical cases, how we manage this case. The first one, we have the leveling of gingival margin in combination with total loss of the buccal wall. We have the right central incisor is condemned to be extracted. The second one, we have 2 central incisors condemned to be extracted in combination with total loss of the buccal bone wall. But in this second case, we have an uneven of gingival margin. In the third one, we have not only uneven, but we have a gingival recession in combination with total loss of the buccal wall. The fourth one, we have the gingival recession, the severe bone loss, and the presence of the infection, how we deal with. The fifth one, we have a periodontally compromised patient. We have to replace this 4th central incisor. There is no buccal wall, no palatal wall, no mesial, and the distal bone ridges and all of them, as you can see through the CBCT scans. And the last one that we can consider a nightmare, how we manage cases like we have, for example, the absence of the papilla. This patient not only lost the papilla, but he lost completely the crystal bone in between. And to make our life a little bit more difficult, this patient lost the buccal wall in all of these 2 teeth. So let's start talk about cases that present a leveling of gingival margin. This is the case 1, compromised socket using cortical cancellous graft in order to manage that. So the hopeless tooth was the right central incisor, but we have the leveling of gingival margin. This is the easiest way to manage in our daily practice, and it represents around 8% of our clinical cases that usually bring patients to our office. This patient lost completely the buccal wall. What we did, we extract this tooth, apply minimally invasive procedures. We did the curettage in order to remove the granulation tissue and the remains of periodontal connective tissue. We confirmed the total loss of the buccal wall, as you can see here. And we installed the implant in the correct 3-dimensional position, always in the palatal wall anchorage, and we left a gap around 3 millimeters at the facial aspect. We made the provisional restoration using the same crown from the patient, and we checked this provisional restoration onto the implant, of course, out of occlusion. And we left intentionally what we call a soft tissue gap. That is that we obtained this soft tissue gap through an under contour, a concave contour at the buccal aspect and the proximal aspect. I recommend you to read this paper that was published in 2016. How to select the implant diameter in post-extraction sockets. It was published by my team. And we evaluate 20 clinical cases. This is a clinical research, and we apply the same methodology, always expecting a gap around 3 millimeters, regardless of the tooth to be replaced. And we evaluate the most important area of the implant. We evaluate the cervical or the coronal part of the implant in a mean of follow-up of 3 years. And we evaluate the maintenance of the thickness of the bone graft and incorporated up to the implant platform letter C, 2 millimeters above letter D, and 4 millimeters above letter E. Let's come back to our clinical case. To harvest bone graft from the tuberosity, we need previously a clinical assessment, an X-ray, and a CBCT from the donor area. And to harvest bone, we need to use an IDR chisels. Inside this box, we have six chisels, 6, 8, and 10 millimeters wide. So the chisel has to be placed perpendicularly to the bone extruder. Right after, to go deepen inside the bone, we can change the angulation according to the desired size and width. After going into the planned length, the bone is fractured. And we reshape this graft according to the defect configuration in order to restore the bone architecture, the bone wall that the patient had lost. And we also match the coronal part of the graft with the outline of the gingival margin. And we crush the remaining bone graft. That's why we are still taking bone from the tuberosity. And we reduce the size of this, this graft as much as you can see here, in order to fill the gaps. And take a look that the implant was placed at 3 millimeters from gingival margin in the apical direction, but the bone graft only 2 millimeters below gingival margin. Better saying, the bone graft was placed at 1 millimeter over the implant platform. And we installed this provisional restoration immediately. But what's gonna happen with the soft tissue if we change the position of the graft in the coronal direction? Take a look what happened. The soft tissue obeyed the orders. The soft tissue has been changed in the coronal direction. We have the coronal displacement of soft tissue. We don't touch in this provisional restoration for at least 3 months. After 3 months, to push the soft tissue in the apical direction, we added composite resin 0.5 millimeters a week for 2 or 3 weeks. After we got it, and as we have the leveling of gingival margin, we remove this provisional restoration and we evaluate the maintenance of the papillary height position. It's the same height of the opposite side, and the maintenance of the anatomical contour of soft tissue, as you can see here. So it was taken impression. This is the final zirconia abutments over the implant, and we deliver the final restoration, a cemented restoration, a porcelain restoration. This is the post-op after 6 years. We have not only the maintenance of the anatomical contour, but we still have the 3 millimeters of bone completely remodeled at the buccal aspect. So I can state that if we have around 3 millimeters of bone at the buccal aspect, we do not need to compensate with a soft tissue graft. This is another article that I would like to share with you. This is another clinical research that we evaluate 18 cases, all of them presented compromised sockets, total loss of the buccal bone wall, and we performed the IDR technique in all of them. And we evaluate this clinical case in a mean of follow-up of 58 months follow-up. And according to our finds, no recession occurred during the evaluated period, and the mean mesial papillary level and this distal papillary level is likely increased over time. That's amazing. So case 2, how to manage case that we have a small gingival recession or uneven of gingival margin using cortical cancellous graft in compromised sockets. Let's take a look at this clinical case. We have two central incisors condemned to be extracted, but in the right side, the hopeless tooth presented a gingival recession around 1.5 millimeters in height. But to make our life a little bit more difficult, this patient had a thin periodontal biotype. And through CBCT scan, we realized that the patient lost completely the buccal wall in both central incisors. But what are the limitations of using bone graft from the tuberosity to change the soft tissue in the corneal direction without adding any connective tissue graft? Let's take a look what we did here. First of all, we treat the left central incisor. As you can see here, we have the total loss of the buccal wall. We extract this tooth, we clean the socket, we install the implant in the right position, we confirm the loss of the buccal wall, as you can see here. We harvest bone graft from the left tuberosity and we match the graft according to the defect configuration. We really shape this graft according to the defect size and height. And between the cortical cancellous graft and the implant surface, we pack particulate bone as a bone filler just to fully fill these gaps. And we made this provisional restoration immediately. But in the left central incisor, we weren't expect any change in the soft tissue in the corneal direction. That's why we promoted here a gingival sealing. So the implant was placed 3 millimeters below gingival margin, but the graft only 2 millimeters below gingival margin. Let's have a look at this illustration in order to notice what's the main aim of the bone reconstruction using immediate dentoalveolar restoration technique. Pay attention that in this illustration, we have already inserted the implant in the right position. We made our provisional restoration with ideal emergence profile. We left an under contour underneath the soft tissue. This is really important. And we use buccal cortical cancellous block bone graft to restore the buccal wall, plus particulate bone graft harvest from the same donor area as a bone filler. That's all we do. And we left intentionally what we call a soft tissue gap that is gonna be filled with blood clot that comes from the socket, from the periosteum of the remaining bone, and of course from the graft that's well vascularized. After 3 months after everything was going very, very nicely with the left central incisor, we decided to treat the right central incisor. The periodontal pocket was around 8 millimeters in height. In this patient presented the loss of the buccal wall. We extract this tooth, we confirmed the loss of the buccal wall, as you can see here, pressing the periodontal probe at the facial aspect. And we installed the implant in the palatal wall anchorage, and we left a gap around 3 millimeters at the buccal aspect. We harvest bone graft from the right tuberosity from the same side, and take a look how vascularized is this graft. And we fully fill this gap with particulate bone, and we left bone graft above the implant platform, like this. So in this right central incisor, the implant was placed, as we have a gingival recession around 1.5 millimeters, the implant was placed between 1.5 and 2 millimeters below gingival margin, and the graft 1 millimeter above the implant platform. Better saying, around 1.5 millimeters below gingival margin. And we made our provisional restoration with ideal emergence profile, regardless of the gingival recession, the uneven of gingival margin. And we left the finishing line of this provisional crown in the same level of the outline of gingival margin of the opposite side. And we left a soft tissue gap here. And we went to tuberosity. Remember that the flap was still open. We collect blood and we inject this blood in order to fit completely this area between outline of gingival margin in the cervical area of this provisional restoration. And we wait for 5 minutes and we send this patient home. Pay attention what happened with the soft tissue. We have the, corneal displacement of soft tissue. We remove this provisional restoration and we noticed that the biological width was reestablished. We have 3 millimeters from gingival margin in both sides. So more important than one abutment one time is the thicker soft tissue every time. Remember what I said before, the dream came true, because now we have a thick buccal wall and thick soft tissue. So it was taken impression, it was made the final restoration, screw retained porcelain restoration in this case. This is the CBCT scan that was taken after 7 years. We have here the maintenance of the thickness and height of bone grafted. And the bone graft that was placed above the implant platform still remain and remodeled above the implant platform. And here you can see the connection between the remaining bone and the bone grafted in both sides, the right and the left side. So we got the hard tissue stability. Just to keep in mind how everything started, we have the bone loss in both sensory incisors. 10 years post-op, we have 3 main topics to be evaluated in the soft tissue. We have to confirm the maintenance of the color, the texture, and the volume of soft tissue. So I can say that we got a soft tissue stability. But how we manage cases that we have large gingival recession like this case? This is the case 4, and to treat cases like this, we must use a triple graft. It's a little bit different, the other graft that we discussed before, because this graft has connective tissue layer along with corticocancellous graft in one single piece. This is a 3-layer graft. This is what we call a triple graft. This was the first article in the international scientific literature published by my team in 2009 to manage hard and soft tissue in one single procedure, to do it all in one single step: tooth extraction plus implant installation, triple graft from the tuberosity plus immediate provisionalization. This is another article that was published at Journal of Prosthetic Dentistry in 2014 using the same methodology. This article was recently published 2 weeks ago. They used of immediate dentoalveolar restoration for the treatment of type 2 and 3 extraction sockets using a triple graft from the maxillary tuberosity. This is a case series. And let's take a look at this case. This patient presented, the hopeless tooth was the right central incisor, and she presented a gingival recession around 4 millimeters in height. This is a patient with a high lip line and total loss of the buccal wall, as you can see through this CBCT scan. So the tooth was extracted, we cleaned the socket, and you can see through the gingiva how thin the soft tissue is. In this case, we did 4 incisions, 2 horizontal incisions at the papillary level and 2 more divergent incisions following the gingival recession pattern. So as we have a gingival recession around 4 millimeters, the implant was placed at 1 millimeter below gingival margin. We made our provisional restoration immediately. Of course, with IDR emergence profile, we left here an under contour in order to promote a soft tissue accommodation. To harvest triple graft from the tuberosity, we need to evaluate clinically, tomographically, and through X-ray. And through soft tissue CBCT scan, we can accurately evaluate the height and the width of soft tissue available and the height and width of hard tissue available. So prior to the surgery, we know where to take the bone. So let's take a look at this step by step. We usually do 3 incisions. One of the incisions is parallel to the distal aspect of the last molar, following 2 more perpendicular incisions touching the crystal bone. As you can see here, this is the 4th incision touching the crystal bone. The step 2 is the flap division, leaving a connective tissue layer covering the bone between 1 and 1.5 millimeters in width. The step 3 is the osteotomy. In these cases, we must use a straight chisel, the flat one. And the chisel has to be placed as perpendicular as possible to the bone structure. Right after to go deepen approximately between 2 and 3 millimeters, we change the angulation of this chisel, leaving as parallel as possible to the connective tissue layer in order to remove a uniform layer of this triple graft. As soon as we go until the planar length, the bone was fractured, and now it's time to do the release incisions, a posterior incision to release this graft. This is a triple graft. And this is the IDR kit that is manufactured in partnership with a German company, Schwerdt company. Inside this kit, we have 6 chisels, a bone compactor, and a container to insert the graft as soon as this bone is taken from the tuberosity. So we have 3-layer graft: connective tissue, cortical, and marrow bone. Through this histological section, we can clearly see here the connective tissue, the periosteum, cortical, and marrow bone. So we have 4 sources of the nutrition ready to be transplanted from the donor side to the receptor side. What's the ideal position of this graft? The ideal position is having and leaving the connective tissue turned toward the soft tissue and the marrow portion to the implant body. But in between, we should insert particulate bone to fill the gaps. Pay attention that 1 stitch was enough to hold the graft in the right position, and 2 more stitches in both papillas. And we left the outline of gingival margin in the same level of the gingival margin of the opposite side. It's not necessary to do an overbuild. 4 months later, we can see here that the biological width was retrieved. And I want to also call your attention that we have a relevant thickness of soft tissue at the implant position. This is the final abutment in place, but pay attention that the anatomical contour of this, the gingival margin, both sides, very similar. So this is the final ceramic crowns in place after being cemented. So here you can see the biotype conversion. Before and after, we had a thin periodontal biotype, but we have now a thick periodontal biotype. And this is the final outcome. So we have the breakdown in aesthetics in the beginning, but now we can see the harmony between the gingival margin and papillary height position. And now you can see here the balance between the lips, the gingival architecture, and the final restoration. And this is the CT scan that was taken after 11 years. The maintenance of the thickness of the bone graft, the new buccal wall, is still remain in the same height and thickness. How about this case? Sorry. That presented gingival recession, bone loss, and infection. We have a severe bone loss in this right canine, as you can see here. We have fistula comes through the sulcus, and through this 3D imagery, you can see the size and the shape of the bone defect. Through prototyping, we evaluate prior to the surgery the height and width of the bone and the soft tissue. So we notice prior to the surgery the challenge that we are going that we need to manage. So in the day of the surgery, the tooth was extracted. We confirmed the loss of the buccal wall, as you can see here, pressing the periodontal probe at the facial aspect. The implant was placed, and we got a primary stability around 40 Newton centimeter, and we harvest from the donor side, from the tuberosity, a triple graft plus particulate bone. And we reshape the graft according to the defect size, defect shape over the prototyping. And we install and we insert a triple graft in the receptor site underneath the soft tissue plus particulate bone as a bone filler. And we install our provisional restoration immediately. And we left part of this graft exposed below gingival margin. And we did, after that, we did the suture. Just simple stitch using 6 or 60 or 70 suture. After 3 months, after hard and soft tissue is being healed, we have the improvement in soft tissue thickness. It was taken impression, it was made the final restoration. Here you can see here you can see the maintenance of the anatomical contour of soft tissue. In 3 years, we have the new buccal wall completely stable. Just a quick remind how everything started. So again, we have the biotype conversion. We had in the beginning a thin periodontal biotype. Now you can see a thick periodontal biotype. Everything was solved, was managed in one single shot. The follow-up after 5 years, we have the maintenance of the gingival margin papillary height position. But take a look at this CBCT scan. After 5 years, we have the thickness of the new buccal wall and the thickness of soft tissue, relevant thickness in both. And the bone graft that was placed above the implant platform still remain and remodel above the implant platform. And here you can see only vital bone tissue. This outcome can be obtained only when we use autogenous bone graft. And we use this clinical case to illustrate this article that was published by the International Journal of Aesthetic Dentistry in 2017. So, next case, is it possible to use autogenous maxillary tuberosity graft in bone reconstruction in several periodontally compromised teeth? Let's follow this case very quickly. This is a periodontally compromised patient, many condemned teeth in the upper and the lower jaw. Through this CBCT scan, we notice that we are going to extract 8 teeth in the upper jaw and 2 more teeth in the lower jaw. And we decide to keep these 3 teeth in the upper jaw, both canines and the left first premolar. On the day of the surgery, we extract these teeth as traumatically as we could. We cleaned the socket and we did the implant installation, of course, using a guided surgery. And we left 3 millimeters of gap at the buccal aspect. This is the protocol for selection of the implant diameter in post-extraction socket that was launched by my team in 2014. How to select the implant diameter in post-extraction socket. It was a new approach, always expecting 3 millimeters of gap at the buccal aspect, regardless of the tooth to be replaced. This is a mathematical rule. The implant diameter is equal the buccal palatal distance of the socket minus 3, as simple as it. So the implants were installed in the right position, and we also extract 2 teeth in the posterior area in the left side, the right side, the second premolar, the first molar. We did the site preparation plus implant installation, and we went to the tuberosity, the right and the left side. And we harvest tuberosity using handle instruments. We only did the suture in the donor sides, in both sides, the right and the left. All bone that we harvested, it was harvested, we insert in a container, and pay attention to the size of these block bones. I recommend you to read this paper that was published by my team and the team from Stony Brook University in New York, Georgios Romanos and his team, the role of the maxillary tuberosity in periodontology and implant dentistry. This is a literature review. So the half part of this graft was reshaped according to the defect configuration, and the other half was crushed in order to reduce the size of the particles to allow us the insertion of this graft as in the best way possible. Inside this container, we have all we need to promote better bone graft incorporation. We have bone and we have blood. So we did the bone reconstruction in anterior zone to restore the buccal wall, the palatal wall, the mesial and the distal bone ridge using autogenous bone graft harvest from the maxillary tuberosity. And we did the same in both arches, in the upper and the lower arch. As you can see here, we can see here the presence of bone graft all around these implants. And we use, just pay attention that we use flapless surgery in the receptor areas, not only in post-extraction socket, but also in the healed sides. So we install this provisional bridge over this implant, 3 provisional bridges in the upper jaw and 1 more bridge in the lower jaw. Sutures only in the donor sites, in the tuberosity areas. Everything was solved in one single shot, one single surgery. This is the middle post-op. No bleeding, no pain, no swallow, nothing. It's amazing. 2 weeks post-op, soft tissue is gonna be healed in between. It's all around this provisional restoration. 3 months post-op. And here you can see that we remove this provisional restoration in order to evaluate the improvement in the quality of this soft tissue. Just to make a comparison, right after the extraction, after implant installation, bone reconstruction, and 3 months later, you can see the improvement in the buccal palatal dimensions of these peri-implantar tissues. And you can see the same phenomenon again, the biotype conversion. We had in the beginning a thin periodontal biotype, and now you can see a thick periodontal biotype. Now, I would like to share with you the CBCT scan of this clinical case 3 months after we applied the IDR technique. From the right side to the left side. Let's start with the first molar. You can follow and you can see the presence of bone all around this implant. Here, the first premolar. Now, the right lateral incisor, the right central incisor, the left central incisor, the left lateral incisor, and also in the second premolar in the left side and in the first molar. The presence of bone, autogenous bone, completely remodeled all around this implant. And how about the behavior of this graft in the lower jaw? Is absolutely the same as you can see here. 3 months later, we have the maintenance of the anatomical contour of soft tissue and the improvement in soft tissue thickness and an improvement in the papillary, not only the thickness, but the papillary height. Let's do a simulation in anterior zone to replace this fourth central incisor after teeth extraction, implant installation, and bone reconstruction. And here you can see the maintenance of volume and the anatomical contour of soft tissue. If you see the CBCT scan, we can see the presence of the new bone, the buccal, the palatal, and the mesial and the distal bone ridges all around these implants. So now it's time to insert the final restoration. You can do a simulation and pay attention to the relationship between the soft tissue in the cervical area and the final restoration. As soon as we insert the final restoration, only single crowns, screw retainer porcelain restoration, and all of these implants. This is a comparison before and after. As I said before, from the occlusal view, only single crowns in all of these implants. I recommend you to read this paper that was published in 2019 by IJPRD, the use of the middle dentoalveolar restoration combined with osteodesification in periodontally compromised extraction sites. To finish my speech, I would like to share with you the last clinical case. This is what we call a nightmare in our daily practice, and I think you'll think the same. Using corticocancellous graft. Let's take a look at this case. This patient lost completely the papilla between central incisors. The papillae were partially lost between central and the lateral incisors. And we have a huge difference between the current gingival architecture position and the original one. And we have to move this gingival architecture in the cornal direction. But to make our life a little bit worse, this patient had a high lip line. And I wonder, if we extract this teeth, how would we solve this big trouble after that? So, which is the treatment of choice in order to succeed with a very challenging clinical case like this? If we go through this direction, what the literature has recommended to us, we would do the teeth extraction, one surgery, bone reconstruction, GBR procedure for vertical and horizontal augmentation, implant installation, one more surgery, soft tissue graft, maybe 2 or 3 in order to improve the keratinized tissue and the papillae creation, and one more surgery for implants uncovery. In total, maybe between 5 and 6 surgery. But if we go into this direction, we would expect some unpredictable of this outcome. Talk about the gingival margin position and papillary position when we think in excellence in aesthetics. So instead of doing that, it was performed here is low orthodontic extrusion. First of all, we did extrusion in the right central incisor. 3 months later, we did extrusion in the left central incisor. 9 months since the beginning, we have the end of the first stage. And here the end of the extrusion, 1 year since the beginning. At this point, it was accomplished here, the site, the teeth preparation plus the provisional crown installation. And here we have 6 months of stabilization. So in total, the orthodontic treatment lasts 1.5 years. But pay attention, a huge improvement, a relevant improvement at the gingival architecture position. But we still have the crestal bone deficiency between these two central incisors. Despite we have a good amount of available bone in both tuberosities and the right and the left side, this patient lost completely the buccal wall in both central incisors and all of them. So we removed the braces. It was taken impression. We obtained the master cast, and over this stone cast, we manufactured this provisional restoration plus the surgical guide. And we did the customization of this new emergence profile over this stone cast. Nowadays, all of this step we are doing digital, in a digital way. Let's follow some short videos in order to notice what we did here. First of all, we performed the periodontal pocket evaluation, and we confirmed the total loss, total loss of the buccal wall in both central incisors. Here you can see that we did the teeth extraction as traumatically as it was possible, and we did the site preparation plus the implant installation. We installed both implants in the right position, 3 millimeters from gingival margin in the apical direction. This was the surgical guide that we used to insert the implants. After implant placement, we performed here our provisional bridge with ideal emergence profile. We harvest bone graft from the tuberosity to restore the defects. All bone that we harvest from the tuberosity, we insert in a container rich in blood, and we start bone reconstruction. First of all, we restore both buccal walls with cortical cancellous graft as a bone shell. And after that, we crush the remaining bone graft using the same tool, a rounder, in order to reduce the size of the particles and to facilitate the insertion and compaction of this particle into the gaps. But it was still missing to restore the crestal bone. This is why we are doing here underneath the papilla, very careful, an incision using microblades, and we did the curettage. We clean this area to remove the granulation tissue, and after that, we packed particulate bone to restore this crestal bone underneath the papilla, very careful. So we did the bone reconstruction, and we restore both buccal walls that the patient lost plus the crestal bone. Immediately after bone reconstruction, we installed the provisional bridge. 3 months post-op, make a comparison how everything started in the day of the surgery. You can see here the maintenance of the anatomical contour of soft tissue. And 6 months post-op. That's why I recommend you to use platform switching implant. Take a look at the bone stability in the mesial distal aspect and pay attention to the new buccal wall completely remodeled between implants. So we remove this provisional restoration, and let's evaluate the periodontal biotype. And again, we have the same phenomenon. We improve the gingival biotype at the implant position. Now you can see a thick periodontal biotype in both implants, but in the neighboring teeth, we have a thin periodontal biotype. So our planning was 4 porcelain contact lenses in the lateral incisor and canines, in 2 zirconia blood abutments plus 2 porcelain restoration, 2 porcelain crowns over these implants. We check these abutments over the implants, and pay attention that I want to call your attention here that the bone is completely remodeled at the crestal bone and it's still stable. So after we deliver the final restoration, the porcelain restorations in place, just make a comparison how everything started. We have here a relevant improvement at the gingival architecture position. And this is the post-op after 5 years. We have not only the maintenance of the anatomical contour around this final restoration, but the maintenance of the outline of gingival margin papillary height position and the maintenance of volume of soft tissue, as you can see here. The final outcomes, the patient is very happy about this result. We have the harmony between the lips, the gingival architecture, and the final restorations, just to keep in mind how everything started. And we gave her back the self-esteem. We use this clinical case as a multidisciplinary approach using slow orthodontic extrusion and immediate dental restoration technique. It was published by the Quintessence of Dental Technology in 2018. So take home message. Don't remove the bone, just move it from the donor side to the receptor side. What are the main advantages of using this concept, the IDR technique? First of all, the preservation of the natural biology. We use this graft as a biological membrane. The maintenance of gingival architecture. It's a flapless procedure. The reduction in the number of interventions. It's a single procedure. And the reduction in the treatment costs. We only use autogenous bone graft. This technique has a high versatility. It can be used for the reconstruction of one or more bone walls and one or several condemned teeth, reconstruction of hard and soft tissue in case that we have the combination between bone loss and gingival recession, the reconstruction of papilla and crystal bone in case that we have the crystal bone loss, and improve implant primary stability when we have low or no remaining bone. Some requirements for the technique's success. First of all, knowledge in surgery, implantology, periodontics, and prosthesis. Training with the techniques, minimally invasive dental extraction, implant installation, fresh extraction sockets. Third, harvesting bone graft from tuberosity. You have to know how to take bone in the easiest way possible, and how to build the provisional restoration with a suitable emergence profile. We know that IDR is a technique sensitive, that it demands training. That's why we created several years ago the IDR hands-on course. This is a global training, 2 days theoretical classes and 1 day hands-on. During the hands-on, you are going to apply all the steps related to the technique in special models, IDR models developed for IDR courses. At the end of the course, you'll be ready to apply this technique in your patient's mouth. If you are interested, please contact us. In our, here you have 2 emails address, cursos@rosodontologia.com.br and my personal email, José Carlos@rosodontologia.com.br for more information. And this is the new platform, the IDR online education. I'm very excited about this project. This is a 2 days course, recorded courses for those people that cannot come for our courses somewhere here in Brazil or maybe United States, North America, Europe, Asia, wherever we have courses, but you're not able to go there. You can watch this recorded course, 23 main topics on IDR we use here. So now I have a message for you. This is a unique and comprehensive course on the IDR technique. I included a series of modules that will discuss the most important and relevant topics on IDR. And regardless of the level of the clinician's skills and individual experience, this course will give you many benefits to improve your daily practice in the treatment of compromised sockets and also in intact sockets. At the end of the course, you will understand why thousands of dentists around the world are applying this technique in their patients and having excellent aesthetic outcomes. And we can watch this course wherever you are at any time and lifetime access. For more information, go to picosonline.com. All about the program, all information that you need for this course you will find in this platform, picosonline.com. So guys, thank you very much for your attention and for your patience. Here you can see all the address and contacts that we have: Instagram, Facebook, my website, and my personal email. If you are interested and to discuss with some case with me, just let me know and keep in touch with me. So Sanji.
Yeah, hi. It was mind-blowing, wonderful seminar. You can stop sharing, and so that we can.
I'm gonna do that.
So, Dr. Martins, it was amazing. I'll have few quick questions, and then we can, because I believe your time is very precious, and we'll finish it within 5 minutes. First of all, I would like to know how you stabilize the tuberosity graft. Do you need any kind of stabilization, or you just place it and then place the implant?
First of all, you have to know exactly the configurations of the defect using CBCT scan or prototypes. And you can do it also over the prototyping or in the patient's mouth. That's why I suggest you to use some kind of magnification, either using loops of magnification or microscope. But this graft is stabilized by just a position like this. So that's why we spend some time, especially as you are, most of you that you are going to start using this methodology as you are a beginner, you are going to spend some time in order to promote a better bone graft stabilization. But imagine that you are not possible to stabilize in the best way possible. You can compensate the stabilization with the particulate bone. That's why I suggest you to reduce the size of this particle graft in order to fill completely this area in between the cortical cancellous graft and the remaining bone in order to obtain a best, not only bone compaction, but bone graft stabilization.
Oh, thank you. As I remember, when I heard you for the first time at Urban Symposium, you were more, you focused more on to going for a partial thickness incision into the tuberosity, so that when you are taking out the tuberosity graft, the outer surface has certain connective tissue, so that you get both, the best of both, the connective tissue and the cancellous graft material, where when you are pushing it in the defect area, your connective tissue side is towards the soft tissue.
Yes, you are right. But we only use a triple graft that you are asking me. When we have some either gingival recession, okay, this is one of the first indication. When we have some uneven gingival margin, you can use the same concept. And another indication is when we have, for example, you cannot avoid the presence of the infection. So to improve the soft tissue quality and to avoid some kind of bone sequestration, it is indicated to use a soft tissue graft to manage everything in one single step. But in most of the cases, it's not necessary to take soft tissue together with the bone graft. Most of the cases, we use bone graft to restore the defects. You understand what I mean?
Yeah. That means one has to be careful about, one has to understand that what is the biotype. If biotype is thin in that area, then definitely one should go for the 3 grafts combined together. Perfect. Or else it's not required.
Perfect.
Yeah. And do you think that this technique of yours, the IDR technique, is going to or able to replace the classical techniques like GBR, or recently people are doing a lot of partial extraction therapy?
Uh, According the experience of the colleagues around the world, they have some preference. I'm
Yeah.
not here to say that my technique is the best one in the world. No, there are many people, thousands of people around the world applying the same methodology and getting this very nice outcomes. So depends what you have in mind. I always say that depends what kind of bone do you want to have around your implants. Of course, biologically speaking, when we use autogenous bone, you are going to have better outcomes. Make a comparison when we use, for example, biomaterials, some bone substitute. It's not what I am saying. The literature has been saying to us for such a long time that when we use some kind of biomaterial, you have to compensate with connective tissue graft in order to keep the soft tissue or to hold the soft tissue in its original position.
So that is why
But it's
you
a
prefer.
very nice methodology that can be used. It's not difficult. Of course, as I said before, it needs training. But as soon as you finish the training, you are ready to apply this technique in your patients.
So that is why you prefer the autogenous nature of the bone, which has triple graft material or without connective tissue, and particulated graft along with that autogenous. So you apply very little biomaterial into that, the alternatives. You don't.
Yes, I really prefer autogenous bone instead of biomaterials to manage cases like this.
Yeah.
It's a very challenge cases that we need to obtain an excellence in aesthetics. That's why I prefer. And autogenous bone has everything that I need. We have cells, lot of cells, BMPs, growth factors, as I said before, ready to be transplanted from the donor side to the receptor side. We have to know exactly how to manage that, how to take in the easiest way possible, how to do the bone reconstruction, and how to do it all in one single shot. It's not difficult. It's not difficult.
Last question I would like to know, do you have any feel, or have you worked on to thought of working about the dentinal graft, because it is also autogenous in nature and it is biological?
Sorry, what's the question?
The dentinal graft. I mean, like when you take out the tooth, compromised tooth, do you prefer utilizing it as a particulate material along with your IDR technique? Have you ever thought about it? Lining of the tooth and then tooth.
When I extract the tooth,
Yeah.
when I extract the tooth and I have to do only the bone reconstruction, or only the bone regeneration.
Yeah.
I personally prefer of using autogenous bone tissue. Now you can do, if you are not able, because it depends your learning curve, but you are not a very experienced clinician. Instead of doing everything in one single shot, you can take bone, you can do the bone reconstruction, and we can seal the socket with soft tissue, connective tissue harvest from the tuberosity, and we wait for 3 months. In 3 months, you can insert your implants, or you can uncover your implants if you have already inserted, and go one step forward to make our provisional restoration and to do the final restoration.
Okay. So the size of the implant and the implant surface has certain advantages in your, or you have certain preferences for the size which you are using in the anterior aesthetic zone, the implant size, and the surface. Does it matter a lot?
No, doesn't matter. Doesn't matter. More important than the height and the diameter of the implant is the site preparation, because the site preparation is the key in order to obtain better primary stability. So I usually prefer to select my implant digitally through the computer prior to the surgery, the height and width according to the mathematical rule that I explained before, always expecting a gap around 3 millimeters at the buccal aspect. So in the day of the surgery, I have already select my implants. So I'm not worried about that. I'm going one step forward because I'm gonna use a guided surgery to prepare the site to insert my implant, and I know exactly the dimensions of the implant to be inserted.
Okay. Okay. Thank you so much. Thank you so much for the insight. And I believe, as you said, and I also believe into that, that anybody wants to introduce this IDR technique into their practice, please think about going for a training program and then apply it in your practice, because it is the technique is sensitive.
Yeah.
So you need an expertise into that. You need to learn for that. So whenever you get a chance, and as Dr. Jose told about his online program and courses, so people can go for that. And definitely one day, even I would like to come down to your center and spend some time with you and take a course with. Thank you so much.
Thank you so much, Sandeep. It will be a great pleasure to welcome you in some of our IDR courses worldwide. Thank you. Thank you, guys. Thank you for the opportunity to be with you today.
Yeah.
Keep safe.
Okay. Take care and bye-bye and namaste from India.